I think uh, all the infectious causes of acute febrile illness have been covered. So what we are going to do today is to make a comprehensive view that how to approach a patient with fever, because almost every infection that has been taught to you till now can cause fever. It causes fever. So when there is fever, the causes of fevers are more than hundreds, right? So are you going to perform 100 tests for one every individual infection? No, we can't proceed like that. So how to choose an appropriate test, right? So that we are going to discuss today. So what do you think, how to choose an appropriate test out of these hundreds and hundreds of infections? Anyone? Astha Sharma. Astha Sharma, please unmute yourself. Are you there? Avisha, Avisha, Abhinav, Abhishek, Adiba Usman, Aditi Verma. Say something. Unmute yourself and say something. The one I have been asking, they are not answering. In the chat box, people have written something. We will see the probable diagnosis. That is the question. How will we see the probable diagnosis? Okay, we will take the history. Yes, we will take the history. And then, but for history, we should know already that what history we are taking, what is the relevance of that, right? Okay, so what we are going to discuss today, what is fever, hypothermia, what are the definitions, and what is the pathogenesis, what are the different causes, and how to approach for the diagnosis of these infections. So fever, what is fever? Actually, we humans, unlike turtles, geckos, we like to maintain our body temperature at a fixed temperature. We are warm-blooded. Whenever that fixed temperature is raised, then we call it fever. And fever is different from hyperpyrexia or hyperthermia. In fever, there is the thermostat set point of the hypothalamus is reset at a higher level. So body has reset its temperature at a higher level. That is fever. Whereas hyperthermia is when the body's temperature is becoming higher by bypassing the thermostat, by bypassing the hypothalamus, right? In fever, the hypothalamus has itself set the body's temperature at higher level. In hyperthermia, the hypothalamic thermoregulatory system is usually bypassed. So the thermostat is bypassed, right? And how does the fever occur? In infections, usually the bacterial substances like lipopolysaccharide, they bind to a protein and that initiate the release of interleukins. And these interleukins go to hypothalamus. They stimulate hypothalamus to release uh, prostaglandins and cyclic AMP. As a result of that, there is shivering and increased heat, and the body temperature rises. Right, that is the mechanism of fever. And what are these different bacterial substances? In gram-negative bacteria, there are lipopolysaccharide, which is endotoxin. It is present in all gram-negative organisms, and in gram-positive organisms, apart from lipopolysaccharide, there is also some toxins. For example, Staphylococcus aureus enterotoxin, Staphylococcus aureus toxin, shock syndrome toxin, or group A, group B streptococcal toxin. Now, how to diagnose, how to make the diagnosis of acute febrile illness? As I said, there are numerous causes of uh, acute febrile illness. I mean, all infections, every single infections can present as acute febrile illness. In fact, the chronic infections like tuberculosis can also present as acute febrile illness. So every infection can present as uh, acute febrile illness. Then how to proceed for the diagnosis? So somebody has said that we will take history, we will make a probable diagnosis. Yes, that is right. What we do, we take history, right? The history will tell us something about the disease, and then we do the physical examination. Physical examination will tell us about some associated symptoms, associated signs with the fever, and then we go for some primary investigation, some general investigations like CBC, complete blood picture, etc. So with these things, with history, physical examination, or primary investigation, will certainly give us some clues. And based on those clues, we go for a specific investigation, the specific investigation for particular infection that comes to our mind. Is that right? So we take history, we do physical examination, we do primary investigation or non-specific investigation, and then we go for a specific investigation. There is one thing which is important, that even before taking history, what you need to do is to assess the patient to recognize any emergency. So because some of the febrile conditions are very severe, for example, meningitis, for example, sepsis, for example, cerebral malaria, etc. So first of all, you need to recognize whether this patient who is febrile needs uh, some emergency treatment, or he needs to be stabilized. Because if the patient is not stabilized, then your taking history, physical examination, primary investigation will be of no use if he is suffering from some serious lethal condition, right? So even before taking history, the first thing you should know is to recognize any unusual uh, lethal cause of fever, as I said, like meningitis or cerebral malaria or endocarditis or sepsis, etc. So this is the approach for fever. So in history, physical examination, and primary investigation. Primary investigation will be like a complete blood picture, blood culture, or liver function test, or urine examination, urine analysis, urine culture, chest x-ray, or if you are living in an endemic area of certain diseases, in our case, it can be malaria or dengue, you can also prescribe those, although those are specific tests, but you can prescribe those tests also as primary investigation if a disease is really endemic in your region. In our region, it is malaria or dengue, particularly dengue in a particular season. For example, if it is August, September, October, November, and a patient is suffering from fever, so it is very common that he is prescribed for dengue and investigations for dengue as a primary investigation, right? So in history, what we look for is what is the onset of fever, duration of fever, periodicity of fever, change in severity, or any associated illness, or patient had any surgery in previous month also, or he has a history of travel. Travel history will tell you if he had traveled to an area which is endemic to a certain disease, and that disease is not present in your area. So without a travel history, it will be very difficult to diagnose that disease. Right, periodicity, some fever in some diseases have a peculiar pattern. For example, in malaria, periodicity was more important before the use of antibiotic drugs or antibiotics. But still, classically, it is described that in malaria, the fever rises every third day or fourth day, depending on the species of the plasmodium. Or in typhoid, there is a step ladder pattern of rising fever. So these things can give you the clue about the disease. And surgery, if a patient had a surgery, it can be a surgical site infection, right? And contact to animal, birds, ticks, fleas, etc. So these all histories are important for the diagnosis of your infection. Now coming to the physical examination will include general appearance, vital signs, skin and soft tissue examination, neurological evaluation, mental status, nuchal rigidity, focal neurological findings, or if the symptoms are present related to any other system, you will do the systemic examination of that system also, right? So this is history and physical examination. This is certainly going to give you some clue about the the disease or the group of disease. And then you go for primary investigations. As in associated symptoms like headache, meningism, pharyngitis, dysuria, diarrhea, abdominal pain, cough, etc., rashes, arthralgia, hemorrhage. These systems will also give you the clue for the diagnosis. For example, if it is meningism, which is nuchal rigidity, etc., then you will suspect the patient is suffering from meningitis. Pharyngitis is associated with fever, then you will suspect that it is an upper respiratory tract infection. If there is dysuria, you will suspect that it can be urinary tract infection, like that. Rashes are very important because there are a lot of fevers which are associated with rashes or eruptions. Rashes or eruptions. Arthralgia, many diseases like chikungunya, um, dengue, etc., they are associated with joint pains. Eruptions, many fever are associated with rashes or eruptions. So we need to understand what are different type of rashes or eruptions. Macules are usually non-elevated. They are just a skin discoloration, a small skin discoloration like this. They are usually non-infectious. And if they are larger in size, then we call them patch. So the macules are not elevated, they are only the discoloration of the skin. Papules are raised, small in size, they are raised, and when they are less than 5 millimeter, we call them papules, and when they are more than 5 millimeter, we call them plaque, if they are more than 5 mm. And if they are rounded, if the papules are rounded, then we call them nodule. If the surface of the papule is round, we call it a nodule. Okay. So if I think there is a thing which is larger in size, it is called papule. Then they turn into a pustule. Initially, they are filled with clear fluid, but later on, they develop pus into them and they become pustules. Petechiae are they are not raised, they are just small hemorrhages into the skin. When there are tiny small hemorrhages into the skin, they are called petechiae. And when they are slightly bigger in size, then we call them purpura. And when they are very large in size, we call them ecchymosis. So they can be, all these conditions can be associated with fever, and they can give us a clue about the disease. MACUs and ecchymosis are usually not infection associated with fever. They are associated with with infections. But rest of the conditions can be associated with infections. And besides their size, besides their being filled with fluid or not, another important thing about the rashes is where they are present and what is the distribution of them. For example, centrally distributed maculopapular rashes are present in measles, in rubella, in infectious mononucleosis, in erythema infectiosum, which is fifth disease caused by parvovirus B19. In measles, the rashes start from the hairline and they move downwards and palm and soles. In rubella, they also start from hairline downwards, but they clear from the originally affected areas as if they migrate. Right? In measles, all the present at a time, but they are rashes and fever. They are maculopapular exanthem. Infectious mononucleosis or primary HIV infection. Primary HIV infection can also present as just lesion tends to enlarge or it migrates from its original size. So it is called erythema migrans. Erythema migrans. It is initially in smaller in size, then it enlarges. That is called erythema migrans. In acute rheumatic fever, the erythema marginatum, the rashes are enlarging, they increase in size, and they shift from one position to the other position. Other non-infectious causes of rashes are drug-induced collagen vascular disease, malignancy, etc. Now, peripheral eruptions, they are present in Rocky Mountains, Am I audible to you? Anyone? Hello? Audible? Okay, interrupting. So listen. Low eruption, varicella. There are periodic lesions. They are they are present on all over the body, and they on body they are in different stages. At one place they will start just erupting, and other place they are mature pustular eruptions. So they are in different stages at different sides of the body, and they are more prominent on trunk, less prominent on the extremities, and usually they do not involve eyes, etc. On the other hand, smallpox is a disease which has been eliminated. It does not occur nowadays, but we sometimes discuss it. And one of the time is when we talk about the uh, eruptions of chickenpox. We always compare it with the smallpox, because the smallpox eruptions used to be all the eruptions at on with same stage. They are with same stage. They appear at once, and together they disappear. In chickenpox, some eruptions are in early stage, others are in later stage. So they are in different stages of development. Here they are in the same stage of development. And in smallpox, they are more at extremities and less and on the trunk. And in smallpox, the eyes and ears, etc., they are not spared. In fact, it used to be a very important cause of blindness. So smallpox does not occur nowadays, but we compare the uh, eruptions of chickenpox with smallpox, right? So chickenpox are mainly present on trunk, and they are in different stages. Smallpox are mainly present on the extremities. Herpes simplex virus, that is also present with eruptions with the fluid-filled eruptions, and it is characterized by a hallmark group vesicles at the metis base. Rickettsial pox. Rickettsial pox is also associated with vesicles. In rickettsial pox, you will also see a ishar formation at the site of bite of the mite. Jahan par where the insect has bit, you will see a scar formation that is called ishar. Now coming to purpuric eruptions. Purpuric eruptions means skin hemorrhages. When there are tiny skin hemorrhages, we call them petechiae. When they are slightly larger, we call them purpura. So purpuric eruptions are associated with certain infections like acute meningococcemia, Rocky Mountain spotted fever, echinovirus 9 infection, viral hemorrhagic fever, or some of the non-infectious causes can also lead to purpuric eruptions like thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, or small vessel vasculitis. Now coming to the specific diagnosis. So by knowing these things, by taking history, by doing the physical examination or systemic examination, you will certainly reach to certain clues about the infection. If it is present with rashes, what is the nature of rashes, what is the site of rashes, whether it is filled with fluid, whether it is centripetal or centrifugal or what type of rashes are these. So based on these things and with associated symptoms like headache, sore throat, burning micturition, cough, dyspnea, etc., you will get certain clues to proceed with your further investigations. Now, when you think of a specific infection, then you will go for specific infection. You are suspecting diagnosis of bloodstream infection. So first and foremost come in bloodstream infection is sepsis. Sepsis is a life-threatening organ dysfunction caused by dysregulated host response to the infection, whereas septic shock is it is a subset of sepsis in which abnormalities lead to increased mortality. So septic in bloodstream infections, very critical is sepsis or septic shock. But unfortunately, to make the diagnosis of sepsis and septic shock is very difficult. And so there is a criteria called SOFA score, sequential organ failure assessment, which is based on a battery of tests. And on the basis of these tests, you make a score, and on the basis of that score, you will say whether it is sepsis or not, right? So here you will not see in this score blood culture, because blood culture will come after 3 days or 4 days positive, so we can't wait for that long. So for the diagnosis of sepsis, blood culture is not there in the score SOFA score system, but sending a blood culture is very important here, because this will tell you if you find the organism, this will tell you about the organism and what are the drugs you can prescribe for that infection. And other bloodstream infection other than sepsis, if you are suspecting them also, then you will send a blood culture. Blood culture, for prescribing the blood culture, very important is to choose the time of blood culture, the amount of blood that you will send to blood culture for blood culture, and how many samples you are going to send for blood culture. So very important is the time. You should send the sample as soon as possible after the onset of clinical symptoms, or as soon as possible when the patient has come to the hospital. And preferably, the sample should be collected before starting the antimicrobial therapy. Because if you have collected the sample after starting the antimicrobial therapy, the chances are that you will not get any bug in the blood culture. And if the patient is already on antibiotics, then if you collect the sample before administration of the second dose, if you collect the sample just before the next dose, then it increases the chances of isolation of the bacteria in blood culture. Right. So how much blood you should culture? You should culture at least 5 to 10 ml blood in one culture bottle. And like these, you have to send two culture bottle in one set. So 5 to 10 ml blood in one culture bottle you will send, and these two culture bottle like this with 5 to 10 ml blood you will send, and this will be called one blood culture set. One blood culture set which includes two bottles, and each bottle containing 5 to 10 ml blood. So you have to send such two bottles set uh, 2 or 3 times, right? Within one at an interval of time. So if you send only one culture set, the sensitivity of doing blood culture is 73.1%. If you send two culture bottles, two sets, which means four bottles, the sensitivity of blood culture is 89.7%. And if you send three bottles, three culture bottles set, the sensitivity of the test is 98.3%. So you need to send blood culture with all sterile precautions, because if you do not send blood with sterile precautions, all the flora of skin will come into the blood, and it will lead to a misdiagnosis. Misdiagnosis, not only misdiagnosis but also mistreatment. mistreatment, because the antibiotic sensitivity pattern that will come, it will come of the skin flora and not of the bug which is actually causing the disease, not of the bacteria which is actually causing the disease. So blood culture is very important in bloodstream infection and enteric fever, even in pneumonia and meningitis. You can also find the bacteria in blood. So another is viral hemorrhagic fever. Viral hemorrhagic fever, if you are suspecting the patient is having viral hemorrhagic fever, first thing that should come to your mind is which viral hemorrhagic fever is prevalent in your area, in your geographical area, right? Because there are a lot of viral hemorrhagic fever and large number of viral hemorrhagic fever like dengue, arenavirus, bunyavirus, filovirus, Ebola, Marburg infection, Rift Valley fever in Africa, Lassa fever in Africa, and yellow fever in Africa, South America. So many of the viral hemorrhagic fever which are not present in India, like yellow fever, Ebola, or Marburg, so you will not prescribe the test for them. For if you are in India, particularly in Delhi, the first thing, if as a viral hemorrhagic fever should come to your mind is dengue. Dengue. So for dengue, what test you are going to prescribe? Either the antigen detection test or antibody detection test or RT-PCR. RT-PCR. And in dengue, very important is the how to choose which test you are going to prescribe for, because if you give antigen detection, because in dengue fever remains there for 8 to 9 days, and if the patient has come at 8th day or 9th day and you will prescribe antigen detection test, will come negative. Or if the patient has come to you first day of the fever and you prescribe antibody detection test, it will come as negative, right? So if the patient is in less than 5 days of onset of fever, then you should prescribe antigen detection test. And if it is more than 5 days, you should prescribe antibody detection test. And preferably, if you prescribe both of them, then the chances are more for your diagnosis. And you can also prescribe RT-PCR, and that also in initial days, because as soon as the antibody starts appearing, the viremia phase is over, and you will not be able to detect virus in blood, right? So what you will do, you will either prescribe NS1 antigen test or IgM antibody test in initial 5 days, NS1 antigen test in later days, IgM antibody test, or if you can prescribe both of them, then it is better. So this was, or if you are suspecting any other viral hemorrhagic fever, then we will go for the specific test, PCR, for those infection also. For other infections which are present in India are like Hanta fever or Kirmin-Congo hemorrhagic fever. They are also present in some part of India. Meningitis, if the patient has symptoms, signs and symptoms consistent with meningitis, for example, headache, vomiting, projectile vomiting, nuchal rigidity, and signs of increased intracranial pressure, then you will go for the diagnosis of meningitis. You will go for the test which will lead to the diagnosis of meningitis. In case of meningitis, you will go for CSF glucose level. If they are less than 0.6 millimole per liter, it is suggestive of bacterial meningitis. CSF protein level, if it is more than 2.5 gram per liter, it is suggestive of bacterial meningitis. Or peripheral white blood cell count. Serum sodium level, if it is less than 135 millimole per liter. Or these are non-specific tests, but they are more useful in diagnosis. As a microbiologist, I should jump directly to the CSF culture, wet mount, etc. But these tests are also very useful. And then you will go for the CSF culture, wet mount, India ink, gram stain, etc. And if you are suspecting a viral cause of meningitis, then you will go for RT-PCR for viral cause. Viral cause, right? Why do we do India Inc. in CSF? Anyone? India Inc. wet mount. We do it for what? Hello. Yes, Cryptococcus. Cryptococcus. India Inc. For Neisseria, we won't do it. We'll do culture for it. Cryptococcus. Mainly we do it for Cryptococcus, and any other test for Cryptococcus, we can do cryptococcal antigen test also in CSR, which also tells that I am audible. Okay. So other infection other than meningitis, intracranial infection can be subdural empyema, sinus, septic cavernous sinus thrombosis, septic thrombosis of superior sagittal sinus, or brain abscess. In all these infections, you will look for focal neurological sign in physical examination, and in investigation you will go for radiological investigations. And if you have a choice, you can collect a sample from brain abscess. For example, if there is surgery going on, and you can collect the sample, then you can collect sample for these brain abscess, etc. And in brain abscess, you should notice that you should send the samples for anaerobic culture also, because many a times brain abscess is caused by anaerobic organism. If you send only aerobic culture, it will not, chances are that it will not come positive in aerobic culture. Now, viral respiratory tract illnesses like influenza, avian swine influenza, SARS, MERS, and the SARS-CoV-2, the recent pandemic, they all are viral respiratory tract illnesses. Most common cause of fever, acute febrile illness, is viral respiratory tract illnesses, and most of the time those viral respiratory tract infections are not very severe. They are restricted to only upper respiratory tract, and usually we do not prescribe any specific test for that. But these severe infections, they can also sometimes present initially as upper respiratory tract infection. So we go for their diagnosis. Gold standard tests are usually culture, but doing a culture for virus is really difficult, and we do not do it for the purpose of diagnosis. We only do it for research purpose. So the best practical test for the diagnosis of viral infection is RT-PCR on respiratory samples. Bronchoalveolar lavage, or throat swab, or nasopharyngeal swab. Now coming to malaria. Malaria, if there is high temperature with periodicity or without periodicity, because nowadays it is very rare to see periodicity because everybody take antibiotic drugs. So to see that peculiar classical periodicity is very rare nowadays. So for the diagnosis of malaria, you will do microscopy is undoubtedly most specific and very sensitive. It is gold standard, but it is very much subjected. It very much associated with the subjectivity. Who is seeing that microscopy slide, and for how long you are seeing that microscopy slide. So a more practical test is to do the antigen detection test. And other tests are quantitative Buffy code, in which we take a fluorescent dye, and we centrifuge the blood sample, and we look for RBC containing any amount of DNA, because that fluorescent dye will give fluorescence. It will bind to DNA, and normally RBC does not have DNA. If it is infected with parasite, it will have DNA and it will give fluorescence. PCR, we can do PCR for malarial parasite. Common acute febrile illnesses, upper respiratory tract we have discussed, malaria we have discussed, pneumonia, you will take BAL or upper respiratory tract specimen for pneumonia also. Viral hemorrhagic fever we have discussed. Enteric fever, the best test initial days is blood culture, and then you can go for antibody detection or stool culture or urine culture. Urine culture, when are you going to do the urine culture? If the patient is complaining with fever, with acute febrile illness, if he is complaining with chills and rigors and burning micturition, then you will go for urine culture. And very important thing in urine culture is to collect a clean catch midstream urine, because the urinary tract is not sterile. There will always be present some bacteria in the urinary tract, the external urinary tract, in urethra particularly. So those organisms can lead to a misdiagnosis. So there are two things. One, that you need to collect the sample, clean catch midstream urine, which means you will discard the initial one third of urine, collect the second one third in the clean specimen. Another thing in urine culture is that we do a semi-quantitative culture. We do a quantitative, semi-quantitative culture in which we measure the colonies, how many bacteria are present in one particular amount of urine. And if they are more than a certain amount, then only we say it is urinary tract infection caused by this organism. Hepatitis, if in physical examination you find the patient is icteric, there is jaundice, or even if you do not find jaundice or icterus, your initial tests are suggestive of liver function test, are suggestive that they are disarranged, then you go for the specific test for hepatitis. And for hepatitis B, you do antigen detection test, hepatitis B surface antigen. And for hepatitis C, you go for anti-HCV antibody as a screening test. And for hepatitis A and E, you can go for antibody as well as for RT-PCR and stool for the detection of hepatitis A and E antigen. These are screening tests, HBsAg and anti-HCV antibody. If they come positive, you can then go for the HBV DNA or HCV RNA for the viral load and for confirmation of the diagnosis, and also for the progression or the treatment. Uh, what is the effect of treatment, right? Chronic tests in tuberculosis. Usually, tuberculosis is a chronic infection. It will present as a chronic fever, but sometimes in India, particularly, it remains there in the body, silently present, and it presents as an acute fever, present as acute febrile illness also. So for that, you will go for chest X-ray and sputum AFP and culture. And in physical examination, if you see any soft tissue infection or abscess, you will go for the culture and microscopy for that soft tissue infection, pus culture or swab culture or something, right? Or if the patient is saying he is suffering from pharyngitis or sore throat, then you will take a swab from throat also and you will send it for culture, right? That's all about the I mean, some it must have given you some clue how to proceed for the diagnosis of acute febrile illness. And if doing after these things you are not able to diagnose the disease, the fever, then what will happen? What will you call that condition? If despite these history and physical examination and these tests, the primary test and specific test, you are not able to diagnose the disease, what would you call that? Anyone? PUO. Karthike is saying PUO, which means pyroxia of unknown origin. That is a different topic. The today's topic was about acute febrile illness. But if despite all these you are not able to diagnose, that condition is called pyrexia or fever of unknown origin, PUO or FUO. There is a definition of it clear-cut definition, and there are certain protocols that you will follow if you are not able to diagnose it. So it was about the acute febrile illness. Any questions do you have?